Good evening, everybody, and welcome all of you to the live program number 153 at Orthopedic Principles. We are back with our amazing faculty, Dr. Sandeep Patel from PGIMR, Chandigarh, India. Dr. Sandeep Patel completed his residency at the PGIMR Institute, and now he currently works as assistant professor in the same institute. Dr. Patel has several publications to his credit and has written several book chapters as well. He's also one of the contributors for our textbook of orthopedic principles. So today, it's my great honor to bring back Dr. Sandeep Patel for this fantastic live program. Over to you, Sandeep.
Good evening. Thank you again. It's always wonderful to talk on your platform. Amazing students over there. Today my topic is gonna be current treatment options in ankle trauma, and I will be touching upon the current concepts and emerging trend. We will touch upon some complex trauma and the controversies and how to approach them. It's going to be a completely case-based approach. I'll briefly touch upon some emerging trends throughout my talk during my cases. So, initial, I'll present two cases of a pilon fractures and move on to ankle. So in pilon fracture, one of the concepts is of minimally invasive osteosynthesis. So this is a case of a 55-year-old female, road traffic accident, but it was a low, soft tissue swelling was minimal in this case and there were no comorbidities. So this was a typically a low energy pilon. Overall pilons are two variants. It's a low energy and a high energy. This seemed to be a low energy pilon. We can see the spiral fracture pattern going all the way around to the tibial plafond. On the CD scan, you can see, however, there is a posterior malfracture which is quite visible. So the posterior malleolar fracture is not amendable for MIS. So we had to do an open reduction, plate the fibula, and with the same posterolateral approach, we have fixed the posterior malleolus with a screw. And when it comes to the pilon of the tibia, we could do it with a minimally invasive technique. So these are some of the intraoperative pictures with a small medial window, creating a space for the plate and then sliding the distal tibial locking plate. And once the reduction was perfect, we can put in the screws. So this was the final picture. So minimally invasive osteosynthesis has got a lot of advantages, but remember, it should not be at the expense of reduction. The anatomical reduction is pivotal. So next is another case of a pilon fracture. I selected this case because I wanted to touch upon the column concept and how to approach a pilon fracture. So you can see this case, it's a high energy variant, a lot of comminution, and this one typically has got fracture at the epiphyseal part, that is the intraarticular part. So we need to buttress all the aspects. We got a fracture of the anterior part. We can see a big posterior part almost completely displaced. So this is a high energy trauma. And so this is one concept which has well established over the last 20-25 years, that is span, scan, and fix. So such a high energy trauma, soft tissue is a problem. So the first stage is always to span them with an external fixator. And then we get the scanning done. And this was the CD scan, which clearly shows all the fragments. So we have got the posterior malleolus Workman's fragment, the Chaput fragment. You see the typical lot of displacement over here and the intraarticular fragments. The personality of the fracture can be well appreciated in the 3D CD pictures as well. So how do you typically plan this fracture? So we have to address this part, and this part. So there have been, I mean, typically everything could be done from an anterolateral approach, wherein we go in through this window, flip open the Chaput fragment and try to stabilize this part. But this case is something different. You can see the PITFL injury and the amount of displacement of this. So we have to go posteriorly in this case. So that's exactly why I chose this case to introduce this concept. So how did we go ahead? We used two incision. This is an anterior incision. It's an anterior approach to the ankle pilon. And this one is a posterolateral approach. Everything was done in the lateral position. And when you sway it, we can get this position as well. So this is the posterolateral approach. This is the fibula over here. So if through here we can approach the fibula as well as that tibial posterior Volkmann fragment. And this is the anterior where we have buttressed it with plates, and this is the posterior where you can see the fibula is being plated, and we have buttressed the posterior malleolar fragment of the pilon component as well. So these are the intraoperative pictures which we have taken, and you can see the good reduction and the spanning. We also went ahead and took a intraoperative CD scan, and this is how a 3D CD scan, you can well appreciate the 4 plates wherein we have tried to buttress the plafond, and once we buttress from all the ends, we get a good reduction. So the posterolateral approach is also a good window in pilon fractures. It's not only synonymous with trimalleolar fractures or the posterior malleolus, it is valuable in pilon fractures as well. So well, this is another pilon case. You can see this is again a high energy variant. You have comminution and intraarticular step over here extending all the way to the metaphyseal. So this pilon has got the pilon in before this case had got all the injury in the epiphyseal part. The metaphyseal part comminution was not there. So we did not need any fancy plates in that case. We didn't need any locking plate. We just wanted to buttress all the fragments of the tibial pilon. But here we got a metaphyseal comminution, so we need one stronger plate as well. So again, we spanned it in the first, and then we got a CD scan. You can see the joint depression over here, impaction over here. So here you can see we have used an incision over here to address the joint impaction. This is the medial incision, a small incision over the chaput to put in the screw. So anatomical reduction is the key here. For the metaphyseal part, it is biological reduction. It was a minimally invasive osteosynthesis. So this is a very good case which says that for the intraarticular part, it's always anatomical reduction. There is, there is no shortcut for that. We have to achieve a good reduction. But when it comes for the metaphysis, we can do a functional reduction with the minimally invasive technique. And this is the picture. So well, now moving on to ankle fractures. Seems like a easy thing, but then there are a lot of complex patterns, and those are the exactly cases which I'm going to present in my talk. So I'll be touching upon the posterior malleolar fractures, the trimal fractures, the syndesmosis, the controversies surrounding that, the posterior approaches, which we already touched upon, the deltoid ligament injuries in association with the ankle fracture. How should we go ahead? Should we always repair or should we not? And then finally, the osteoporotic fractures. So to begin with, this is a high energy injury, an ankle fracture. Okay. So this patient came to me after 2 months. So then these were the initial x-rays. You can see it's a high energy. It's almost the talus is punching on towards it. It's also called transsyndesmotic fracture dislocation. So this was the initial x-ray of the person, and whoever has operated, this is what the initial post-operative x-ray. And this patient comes to me exactly with this post-operative x-ray. So if we go back, and then this on an overall grossly, the market seems to be reduced and there is a syndesmotic screw, but then something was not right because when you go back to this case, I could see this shadow over here. This is the chaput fragment, which is equivalent to the posterior malleus, but it's situated anteriorly. And this is a gross syndesmotic injury. So this should have been addressed. And then the second issue was the placement of the plate, which is more like an anterior. So there was something grossly wrong in this. So this was the patient's clinical picture when he came in. So I got a CT scan done. And well, what this is exactly the problem. The chaput is not addressed, but most importantly, the syndesmotic malreduction. Well, my dear friends, syndesmotic malreduction is a real problem. Almost 52% malreductions are there when we have a gross syndesmotic instability associated with an ankle fracture. So they're generally not an easy way to go ahead. They should have been a CT scan initially. They should have understand the fracture pattern. That was not whole. You can see the syndesmotic screw. It's going all the way posteriorly, missing the main part of the tibia as well. And the position of the plate is completely wrong. So then we went ahead to do a revision for the same. So I have done all the markings. We'll be opening through the same incision, but to fix that chaput fragment, I will be also opening anteriorly. So now when we open, you can see how grossly wrong it is. The placement of the plate is wrong. So in order to have the syndesmotic screw, they had to go posteriorly, and hence that screw never cut the syndesmosis. The anteriorly we opened the chaput, the fracture was cleaned, and then the main heart of the procedure is to do a 100% reduction. So we have the facility of intraoperative CT scan, and this is an intraoperative CT scan, and we can see how congruent the syndesmotic reduction is. So this is once we achieve the syndesmotic reduction, we go in through a CD scan and confirm that the reduction is good, and then we pass two syndesmotic screws for that, and then we have addressed the chaput fragment as well. So these are the post-operative X-ray of the same patient, and this is the follow-up after 8 months, where the patient is walking perfectly fine. This is during the lockdown. I asked him to share the video so he could do that. So the learning point from this case was that syndesmotic reduction is of paramount importance. Malreduction is more common, ranging almost up to 52% in some of good studies. But the question is how to reduce syndesmosis. One is to know that the syndesmosis malreduction exists, so that it gives us an insight that we should always carefully see, and then how to reduce syndesmosis. There are a lot of and how to assess whether syndesmosis is reduced or not. So these are some of the good articles wherein they talk about the radiological assessment using a typical lateral view or a mortise view, but then uh, only with a mortise view it's impossible. So this article tells that of a normal ankle, we should always have a C-arm view, and then we should try to match it. The second option, which was propagated by the Muller et al. Right from the beginning, was direct visualization, and I still feel this is one of the gold standard. If you are in doubt, just give in a small incision anteriorly, and then we can see the syndesmotic reduction. So direct visualization, so it's completely reliable. And then we have a very good article in the JOT which compares all the things, and they do stress upon the need of an intraoperative CT scan, but well, that's not available everywhere. But if you have it, it's a good way of assessing the syndesmotic reduction. So the key thing is the syndesmotic malreduction is not acceptable. Well, now let's move on to a trimalleolar fracture. So I chose this case. So this was a 35-year-old male, road traffic accident, pain, swollen, and there was a gross deformity. You can see here the medial malleolus fracture. A lateral view, we can see the posterior malleolus fracture, and the Weber C type of a fibula fracture. So this is a higher fibular fracture. This is a pronation external rotation injury, and the talus is subluxated, which is well expected in such a case. So again, we follow span scan fix in such high energy cases, and then we go ahead with the CD scan. You can understand, see the amount of syndesmotic displacement and the small posterior malleolus which is attached with it. So again, the heart of the procedure is to fix everything. So the posterior malleolus has been buttressed. Again, this is a intraoperative CT scan which we have used, wherein you can actually see how beautifully the syndesmotic reduction is. You can also see the orientation of the plates. It's fun to have a intraoperative CT scan wherein you can really assess the reduction quality of your case. So these are other images. We can get the axial cut, the coronal cuts, and then like similarly in any CD scan. And this was the final postoperative picture of the same, which is showing very good reduction of the mortise. So well, now certain, and again, implant for posterior malleolus. Nowadays we do have locking plates for the same, but 3-4 years down back we did not have it, and I used all the fancy combination, so I thought I should share it in my talk. So this was a very low posterior malleolus with a lot of comminution. So this was a typical distal radius plate wherein I would created a claw-like structure so that it can hold in all those small fragments. A distal radius plate have also been used, and this one was a 1/3 tubular plate where again a hook sort of a construct for a very small posterior malleolus has been done. So this is a posteromedial plate of the proximal tibia, which I have used for a very big posterior malleolus, which needed a good buttress effect. And this is the latest locking plates, which is very anatomical, and it sits to the contour beautifully. Now, supination adduction injury is also a problematic fracture. The basics, the major problem in supination adduction injury is the joint impaction which we encounter, and that needs to be corrected. Though this case I selected is not because of that, but for something else. Apart from that, you can see here we got a very small fibular avulsion because of the adduction nature of the injury. So in such cases, we need to make sure that and surprisingly there's not much of an impaction in this case. So in such cases, these needs to be repaired with a suture anchor or something. So we need to identify the injury pattern and pick up those smaller ligament injuries surrounding them to address the same. So well, moving on to another interesting complex topic is the association of deltoid ligament injuries in a complex ankle fracture. So what is the role of deltoid ligament? So we'll be discussing in impairing stability to the ankle fractures and define the indications and protocols where surgery needs to be done and where it can be avoided. So this is a 22-year-old female, road traffic accident, had an associated humerus fracture and an ankle injury with some swelling. So these were the initial x-rays. Grossly looks normal. Subtle injury, we can make out a small flake of bone over here. So it looks like a very subtle nature of an injury. But are these radiographs enough? Once we have a clinical examination of the same, we can see tenderness of the ankle and the medial malleolus, and squeezing of the distal leg was painful. And you can see all the ecchymosis over here and the distal part of the thigh as well. And that's exactly when you have a knee x-ray, we can see this is a Masonius fracture. That means there is a complete syndesmotic disruption. It's a Weber C, and it's a pronation external rotation injury. But the only thing is, in spite of a medial malleolus, we have a complex deltoid ligament injury, the whole syndesmosis, and then the fracture energy has exited at the top. So additional investigations, we took the CD scan. Surprisingly, the CD scan, if you don't examine clinically, it looks so normal, the CD scan, that, oh, should we really address this? That becomes a big bit of a picture. So the question here is, what is the degree and extent of instability, and what is the extent of stabilization required in this case? So the plans, should we address only the deltoid ligament, or should their syndesmosis also be addressed? So we have to do intraoperative assessment of each instability, and that's exactly why I have picked up this case. So you can see here, we have done an external rotation stress test, and how the syndesmosis is opening when we are doing an external rotation test. You can see the syndesmosis literally opening up when we do it. So that's very much important to do a external rotation stress test to understand the nature of the opening. So then in this case, how do we address the syndesmosis? It can be with the 2 screws or a syndesmotic tightrope. So we thought of using a tightrope in this case because it's more like a ligamentous injury. So we use the syndesmotic tightrope kit in this case. So these are some of the intraoperative images, some completely percutaneous procedures. The syndesmosis is reduced, temporary stabilizing K wire, and then distal to it, we have passed in the guide wire, we have drilled it, and this is the tightrope being passed through it and flipped over here. And then this is before the final tightening. And once we tighten it, we achieve a complete reduction of the syndesmosis. So now the syndesmosis is stabilized. I don't have an image in this, but then again, we repeated an external rotation after the syndesmotic fixation. Talar tilt was still persisting. That means we needed deltoid fixation. Even after syndesmosis stabilization, there was talar tilt and medial opening. So we went ahead with a deltoid fixation. In this case, we did a repair and internal bracing of the deltoid. So this is into the medial malleolus, and this is into the talus. And the third internal bracing is into the sustentaculum tali. And these are the final CM images after fixation. So this was the construct which we achieved of a bracing, internal bracing concept. So the toughest part is to identify the sustentaculum, but that becomes easier with some practice, and you can see how the completely safer trajectory of the screw is there. So this was the immediate post-operative X-ray of the same patient, and this was 6 weeks follow-up, and this was 4 months follow-up with a good range of movement. And then we asked for a video during the lockdown time, and I could get the video with the patient perfectly comfortably walking at 4.5 to 5 months. So the learning point in this case was that Weber C fractures are highly unstable despite no significant Taylor shift seen on the primary X-ray. They need a high index of suspicion and additional investigations. Intraoperative stress images is something which we all should know, and it defines the syndesmosis and the other medial structure instability. Despite no fracture visible, reconstruction of ankle ring is essential to attain stability. So let's move to another case. Similar 30-year male twisting injury. This is the lateral and AP view. So we have got a fibular fracture. There is deltoid ligament injury in this case as well. This is a supination external rotation injury with a deltoid ligament injury here and the gaping seam. So how do we, and this is, once we see the CD scan, we know that it has got a posterior malleolus as well. So this is a supination external rotation 4 injury with the complete ankle ring disrupted anteriorly, posteriorly, medially, and laterally. So these are the CD scans, 3-dimensional. So the injury pattern has to be identified. Here we have the posterior malleolus gone, the fibula fracture, and in the medial structure injury, the syndesmosis from anterior to posterior is torn. And then we have the deltoid ligament injury at the medial. So how do we plan? So we went with a posterolateral approach, the fibula plated, the posterior malleolus plated. So this is the immediate intraoperative X-ray after fixation of posterior malleolus and fibula. The ankle ring looks perfect on this. So we need to do a stress X-ray after this to see what has happened, because most of the time indirectly it will be stabilized. So you can see my hand, I've given an external rotation. So just by fixing the fibula and the posterior malleolus in this case, a supination external rotation injury, the ankle ring became perfect. When the lateral structure was there, there was no opening with external rotation. So we went ahead with the slab and a cast for 2 to 3 weeks, followed by the pneumatic ankle brace for this patient. So why I picked up with, and this is the immediate post-operative X-ray of the same, and this is follow-up of 4 months. So why I chose this was that not always we need deltoid ligament repair. We need to sequentially check intraoperatively. If it is required, we have to add it. This is another case. You see what happens here. It was a similar case. We have fixed the posterior malleolus. We have fixed the fibula as well. And then when we're doing an external rotation test, you can see the opening of the syndesmosis here and the opening over here. So there is a syndesmotic instability in this case. So in the next stage, we put in a syndesmotic screw. So this was before putting the syndesmotic screw. You can see how the deltoid medial side is opening. But after we fixed the syndesmotic screw, there is no tilt medially and the complete deltoid complex got stable. So we have to assess them sequentially and then decide what is required. So sequential fixation is a learning point. Stress examination after each step. Not all deltoid ligament tear require repair. Indirect stability can often be achieved. The ankle ring concept should be understood and we should make it stable. This is another 37-year-old male, road traffic accident, pain, swelling, deformity, ankle widening is there. So this was the case. Intraoperative, before fixing everything, you can see how much displacement is there. Here we have fixed the syndesmotic screw, posterior malleolus. Even after that, there is opening. So this case required a deltoid ligament. So this is a video, a short video of a deltoid ligament repair, which I have made, which I'll be displaying. Not much. It's a short video. So once we open the medial side, we can identify the deltoid ligament here. This is the bare area, and this is the deltoid ligament. You can see how it's got ripped away from the medial malleolus. So we have retracted here, identified the sustentaculum tali, wherein one bracing screw will be put anchor, and another is the talus, wherein the other part of the deltoid ligament is attached over there. So we are clearing and freshening the surface so that the repair can be augmented. Once it's freshened, we drill in the medial malleolus for an anchor, and then we would try to approximate. So this is a anchor with a loaded fiber tape in this case, and once the screw is put over here, in the next stage we would repair the deltoid ligament to this anchor, which will be shown. So these are the threads of the anchor. So these are the fiber tape which will be used to internal brace. So this K-wire is drilled into the sustentaculum tali. We have to confirm it with x-rays, and the other K-wire is the talus. You can see one in the sustentaculum tali, beautifully gone. And once we are confirmed with it, the next stage is to repair the deltoid ligament. So we take the suture anchors and the bite into the torn deltoid ligament. And once we tie this, this will be beautifully approximated. However, you can see we are tying it. But this repair also needs augmentation. That is where we use these fiber tape limbs to augment the repair, one into the sustentaculum and the other one into the talus. So I'll be skipping that part. So this was the final view of the same case. So deltoid ligament injury, we have to identify whether there is instability or not. Medial stability is essential to reconstitute ankle ring. If medial stability cannot be achieved indirectly by lateral stabilization, then we will need repair of the deltoid ligament. So next concept is an osteoporotic fractures. It can be tricky. So this is another upcoming area in ankle where there's a lot of implants developed, a lot of strategies developed to address the osteoporotic ankle. We have a publication where we have discussed the same. So this is something called tibia pro fibula fixation, wherein we take a 1/3 tubular plate, make it into a hook plate, so that in osteoporotic bone the hold can be held in the tibia. Here the purpose is not like a syndesmotic screw, but it's more like getting hold into the tibia. The locking plate is another option which has evolved for osteoporotic fractures. There are other things like a fibular nail and a fibular locking plate. I am not a good we don't have fibular nail over here, and I don't recommend them, but people are coming up with them for osteoporotic fractures. Then hindfoot nails, I mean, this is something out of the box. Initially we feel what is happening for an ankle fracture, hindfoot nail. But this is much popular in the UK, the European side, wherein they have 85 plus 90 years elderly with an ankle fracture. So they like how we do a PF and just go in and put in a nail in 15 minutes. So they just violate the ankle joint, put in a hindfoot nail. It's a short surgery with a hindfoot nail in it, and there are studies which says that it's a good option in elderly. These are definitely not option in those 60s 70s cases, but in the literature hindfoot nail is emerging as an option in extreme elderly for osteoporotic bones, as they can allow early weight bearing. So we have got some articles regarding the same for the use of a hindfoot nail. So these were basically some of the challenging complex cases which we discussed today, and some trends and concepts which have emerged. Thank you.
Thank you, Sandeep, for a fantastic presentation. A lot of new insight, and I'm really happy that you've published as well on the subject. A few questions.
Yeah.
See, one of the cases that you show initially where you put in a plate on the medial side, on the anterolateral, as well as a posterolateral. So are you worried that you're going to create a bone sandwich? You put plates from all sides, there's a potential for devascularization and creating a necrotic bone.
Understood. You are true. But see, the again, what we have to understand is, yeah, the problem is with the devascularization in the distal tibial area and how much. But in all of the cases for tibial pilon, I only use 2 incisions maximum. So so that's how you have to match your incisions. So the case which I showed, wherein I just used an anterior 1 incision and a posterior incision with a good in between window, and if I need to slide in the medial plate, that will always be MIPO. The only thing I use the incision distally is to attain 100% anatomical reduction, but so my dissection will only be there at that intraarticular level, where I have a visualization of the talus as well as the distal tibia. As I go up, all my things convert it into a minimally invasive technique. So it takes some time. I mean, initial cases, exactly where we had problem in approaching those corners, but then as we come across. But yes, that everyone should remember, we should not denude that. I mean, even though I have applied the plates, but my incisions you would have seen initially. So in that case, I didn't plan an anterolateral. I used an anterior incision, so that the distance, because the anterolateral will be more closer towards the fibula, I use an anterior incision, so that from the anterior incision I can go to the medial side as well as the lateral. It's similar for the ankle replacement approach. And then I used a posterior lateral incision. Again, I modified it, took it more away from the fibula. So then there's a good window in between. So we have to plan across with the incision and timing. Again, the next important thing is timing. Never hurry in these cases. I mean, there are times when I've operated 3 weeks down the lane, but most important is to put an X-fix. If you don't put an X-fix, then things are gone.
Thank you, Sandeep, for that. The other one is, see, you mentioned that the intra CT is the best way to see for syndesmotic congruence.
I would not, I mean, yes, it is a very good thing, but I mean, it is definitely the best because you have it in front of you, whether it's reduced or not, you get an option to review it back. But then that facility is limited in a lot of places. But once you're talking about syndesmosis, the best way even today is to give a mini open incision anteriorly. You can just give in an incision of a 2 centimeter, then you can feel it there. So that's why we are still having publications even in 2019-20, where they are still telling that open reduction is the best. Open reduction is the best. I mean, that itself shows the resurgence of publications. Syndesmosis malreduction is a problem. But yes, if we have an intraoperative CT, things are very good. At the moment, we know that the reduction is good. So it's always good to have it.
Okay, Sandeep, thank you for that. Do you have any experience in using ankle arthroscopy as an adjunct? Because there's a lot of talk in the knee where you do a arthroscopy assisted tibial plateau. So what is your take on that? Is it evolving or?
I think, again, even if it comes for the knee also, I would rather say it was a trend 15 years down the lane. Now, I mean, after the emergence of the column concept, the complete tibial plateau management has changed. I mean, this arthroscopic management publications came during the 2005, early 2000s, especially for those lateral plateau fractures, the depression ones which needed elevation. I mean, that is the only indication I see. Apart from that, nowadays with the column concept in the tibial plateau also, we can understand the ripping of the menisci with the open approaches, and that can be done. And once it comes to the ankle, in these gross injuries, I do not find a role. One is I'm not an arthroscopy surgeon, I don't use it. But still, those syndesmotic injuries are the ones where, like the deltoid injury, the PR1, the case I showed, which has a small flake, that is one very good case wherein they can do I mean, I could demonstrate with the stress test that it's gone. But that was a good case where if you have a arthroscope, you can put in an arthroscope, see the syndesmosis torn. But it's good to have it, but it's not a necessity. I mean, trauma surgeons can just follow the other principles and go ahead. It's not always important.
Exactly, Sandeep. You know what? I was just hosting another ankle arthroscopic surgeon, and we discussed a lot about syndesmotic reduction using ankle arthroscopy. So that is the reason why I asked you this question, because you get to see the syndesmosis beautifully during an ankle arthroscopy, isn't it?
Yes. Yeah. Wonderful. You can literally see the tone things being opened.
Thank you, Sandeep, for that. The other question is, if you see a Meissonier fracture, for example, you said the Weber type C, you see a high fibula, you assume that the interosseous membrane is torn, isn't it? So in that case, do you take all these patients to the operation theater and do an examination under anesthesia?
I mean,
How do
well,
you decide who are you going to take for an examination under anesthesia?
see, if that case comes under me, if it goes through me, I know it is there, and I will go look clinically only. I would tell my resident also, just no need of that. Also, first of all, remove the slab, recheck. There will be a lot of swelling and tenderness high up. See, that's why I put in the clinical picture. The clinical picture tells the whole story. That much of ecchymosis all the way up indicates that the syndesmosis and the interosseous membrane is torn. So you saw that case where even the CT scan was wonderfully there. So I mean, that case was someone admitted under someone else, but then he had a proximal humerus fracture. I said, no, there is an ankle. No, can't the ankle be done conservative? I said, wait, I'll come into the OT and will show you what's the problem with an ankle. And that's exactly why I picked up the case. So we need a high index of suspicion, and it's advisable. And I didn't talk about in this case, you needn't take them to the OR always. You just need to do a lateral position stress examination as well. That will also open up the syndesmosis. You just need to make the position patient lie laterally, and with the gravity, the foot will go in the laterally. That will stress the stress open the syndesmosis, and then a mortise view will show you a widened syndesmosis.
So you need to keep the position patient lateral, and technically you need to take an AP view as well, isn't it?
Yeah.
AP mortise.
Basically, the affected limb will come down, and then when it opens up laterally, the syndesmosic space will basically that external rotation stress should go. So it's a gravity hanging. If we make the ankle lie by the end of the radiology table, the ankle will go in. Otherwise, you can wear in the lead apron, just go into the normal. You don't need to take them to the intraoperative. Even in your emergency area only, just give them an external rotation stress and take an X-ray. We can appreciate the opening.
I think the deltoid can be seen is same in the same way, isn't it? The deltoid ligament.
Same thing, because see, the complex is same. Once the talus starts moving laterally, so that's exactly I showed another case wherein I put in a syndesmosis and closed the syndesmotic area. The deltoid couldn't move because the mortise is open. So the concept is like a ring. So the syndesmosis ruptures. So the talus will start coming laterally. If the deltoid is intact, the talus will not come more laterally. Then it will start, the talus will start going posteriorly if there's a posterior malleolus fracture. But then if the deltoid ligament is gone, then it has got extra freedom of the movement. So that's why sequentially we should fix it. The posterior malleolus, the fibula, we fix it. So sometimes with the posterior malleolus fixation, the syndesmosis will become stable. In one case where I shown, then the talus was not moving only. That secondary stabilized the deltoid ligament. So in the next stage, we put in a syndesmotic screw. In one case, after the syndesmotic screw, it became stable. In some times, even after the syndesmotic screw, the opening will be there. So that basically the secondary constraint, apart from the deltoid ligament and the interossei, there is the capsular, the other small ligaments around it, which gets ruptured. So based on the progression of injury. So this was my understanding. Then I went into a recent meta-analysis which says, this is a debate in ankle structure. Should we repair deltoid ligament or no? So if you go and search in the literature, if you go initially, lot of conservative, they didn't do, they just stabilized the lateral part of the fibula. Like some cases, the deltoid becomes stable. And then nowadays, because of we have good options to fix deltoid ligament, people are doing all case deltoid fixation. But that is not the way. That's exactly why
we should go middle path.
We should go middle path. So I have demonstrated all the cases, and then I was surprised. I just went into a meta-analysis, and my understanding was exactly what the meta-analysis told. See, when we have in the pronation external rotation where a Weber C is there, that's a high energy. So a lot of ligaments go. So like the case I shown, so there invariably after fixing everything, still the deltoid will go. So the meta-analysis said in a PER injuries or Weber C injuries, mostly they may need deltoid ligament repair. In a supination external rotation injury, they may not need. So that's exactly, so if we follow that sequential stressing, you will not miss anything.
And the other thing, Sandeep, when overall from your talk, I understood that if you have a C-arm very adjacent to your emergency room, for example, your OT is attached very close to the emergency department, you can just take the patient and get the C-arm, and instead of giving a full anesthesia, you can look for instability, isn't it?
Perfect, perfect. True. I completely agree with you.
So because you cannot take a static, how many times can you take a static image? You cannot take, but the advantage of having a C-arm very close is I think you can just take in and just see across and find if there's a delta ligament or a syndesmotic possibility.
Yes, exactly. I mean, it's always good to have those dynamic views. But then I think with understanding, we will come to know the telltale signs in the cases. And as I said, that stress view in emergency, it's a well-known thing. So whenever we have a high index of suspicion, even if you don't have the normal X-ray, as I said, you just need to apply external rotation stress and get an X-ray, static X-ray. That will also tell. And that's quite a standard principle in emergency medicine protocols.
I think that's all the questions that we have, Sandeep. It was fantastic listening to you. And I think this particular lecture is unique because of the case-based discussions. Because ultimately, we need to encounter patients, and that's where you need to act. Like in the language of evidence, you ask, appraise, and finally you need to act, isn't it?
No, that's why I got this time in a completely case based, I put in a case, then got in the concept, so that even, I mean, these days, so many webinars, we want to catch the attention of the orthopedicians as well. So cases somehow tends to keep them hooked up.
Thank you very much, Sandeep.
Yeah. Thank you.
Okay, let's end the session.